that are in other meetings, particularly judiciary, they'll be over here shortly. We don't have any bills to obviously to entertain or pass, but we do have minutes. We'll have to hold off on approving the minutes as soon as we get quorum. This is the second meeting of the budget review for Health and Family Services. The LRC staff put in the presentation from the DMS on what they'll be presenting today. And Secretary, go ahead and call the roll. What's there?
Representative Duval.
Thank you, Ben.
Here.
Representative
I
Johnson.
don't know why I looked at
Representative Raymer. Representative Wilner. Representative Wilson. Representative Bowling. Representative Bray. Representative Heverin. Representative Moser. Representative Petrie. Representative Williams. Chair Fleming.
I am present. Thank you very much, Ben, for calling that. As you see, we're thin, so we're going to go through, and they'll filter in as soon as they are finished with their committee. Commissioner, Mr. Beckel, if y'all want to go ahead and approach the table. I do appreciate y'all coming back in order to talk about waivers and so forth. I know the chair of A&R goes through and does a testimony, so I don't mind if you don't mind raising your right hand, and if you don't mind, just repeat after me. Do you swear to tell the truth, whole truth, and nothing but the truth?
I do.
Thank you very much. I appreciate that. So in any case, I know you have like 24, 25 slides, and quite a few of these slides have been presented before, and I think in this committee as well as A&R. And if you don't mind, if just sort of go through and sort of highlight some of the things you think is important. I know I'm sorry, I probably should have told you that beforehand before we met, but I think you can probably get through all that. You're pretty talented in doing that. So if you don't mind, we'll do that. You have the floor.
Okay. Thank you. And I'm Lisa Lee, for the record. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
I'm Steve Bechtel. I'm Chief Financial Officer for the Department of Medicaid Services.
So basically, we knew that there were some new members, and we wanted to just give a general overview of the Medicaid program, how we are the largest program that provides medical and health-related services to low-income individuals. We are governed by Title 19 of the Social Security Act. It is a partnership between the federal government and states. Federal government has broad guidelines, and the states are responsible for administering the program, and we have some flexibility, as you can see on this slide. We do receive federal medical assistance percentage from the federal government. We were just in another committee or a committee where we had to explain the difference between the 50-50 match and the 80-20 match. And so traditional Medicaid, we receive 71.48% of every dollar spent from the federal government. And as you can see, administration is only a 50% match. Personnel is included in administration. However, if we have certain positions such as nurses, we do get an enhanced FMAP for those positions. Our information technology also receives an enhanced FMAP. Anything for benefits for our expansion population, which is those individuals between the ages of 18 and 64 who are at or below 138% of the federal poverty level. We get 90% for those individuals. In our Kentucky Children's Health Insurance Program, we receive 80% of those funds from the federal government. Again, the slide has been presented. It's just our at a glance with the number of members. We do like to point out that of the 1.1 million children that live in the state of Kentucky, over 600,000 of those children are qualified for our Medicaid or our Kentucky Children's Health Insurance Program. The expansion members that I spoke about that are below 138% of the federal poverty level total about 485,000 right now. So again, we get 90% of the cost for serving those individuals from the federal government. We have over 69,000 enrolled providers and $18.5 billion expenditures in 2024. Just a map of the enrollment by of Medicaid members, or the percent of the county that is enrolled in Medicaid. And today we were going to talk about our 1915C home and community-based waivers. The department currently administers 6 home and community-based waivers. The acquired brain injury and acquired brain injury for long-term care, our home and community-based, which is the ACB, the HCB, the model waiver 2, which is for independents who are event dependent. And then we have the Michelle P. waiver and the SCL waiver, the supports for community living. So you can see that the individuals served in these programs either have a physical disability or a developmental disability. And that's what makes them eligible for these Medicaid programs. And I think what's really important with this slide is that individuals must meet either nursing facility or intermediate care facility level of care in order to qualify for the waiver programs. So without these waiver programs, the individuals would be in a facility. That is the purpose of the 1915C home and community-based waivers, is to allow individuals to remain in their home or community and receive services. Who's eligible? Again, there's financial eligibility for Medicaid as well as our waiver programs. Waiver programs are a little bit different when we look at eligibility. One of the biggest examples I can give is that children in Medicaid qualify for the services in Medicaid or K-CHIP based on their family income. However, in a 1915C home and community-based waiver, children is the income is only counted for the child. The family income is not considered. If that child, for example, has any form of income coming in, then that's the only income that is counted for their eligibility for the waiver. The whole family income is not counted. We offer various services, and I would point out that many of these services are not covered by Medicare, nor are they covered by commercial insurance. One of for example, the personal care and homemaking that allows individuals to remain in their home, that provides supports for them. Some of the adult day health, adult day training, environmental and minor home modifications, for example, are not included in Medicare or in commercial insurance. We do partner with our sister agencies within the Cabinet for Health and Family Services to help us administer these waiver programs, because some of the expertise, for example, is in behavioral health. So behavioral health helps us with the Michelle P. and the Supports for Community Living waiver. They administer that for us. Likewise, the Department for Aging and Independent Living, they administer the home and community-based waiver, as well as all participant-directed services, and we will get into that in just a minute. So participant-directed services allows an individual who is receiving 1915C waiver services to hire their own providers for non-medical, non-residential waiver services. These individuals can be friends, neighbors, family members, individuals they go to church with, and this just gives them more choice, flexibility, and control over their supports and services. And individuals who are eligible to receive these services are in the acquired brain injury and the acquired brain injury long-term care, home and community-based Michelle P. or supports for community living waivers. Just a little bit of our numbers and our waiver enrollment and waitlist numbers. The funded slots, or how many slots are currently funded, and I know some of our partners don't really like to talk about slots because these are actual people who are enrolled in waivers. So you can see that the field slots indicate the number of individuals who are currently receiving. We do have some reserved slots and that are reserved for individuals who maybe leave the waiver program for a certain amount of time, but we anticipate that they will be coming back into the program. And then there are the number of slots currently available and the total on the waiting list. So that total number on the waiting list is across all waivers. Unduplicated is 13,933. We put that number in there because some of those individuals, for example, in the Michelle P. and the Supports for Community Living waitlist, they may have their name on one or more wait lists. So a total of 13,933 individuals are waiting on services through the 1915C. This is just depicting that the General Assembly did in the last budget include additional waiver slots. So the 2025 slots were 650 were already assigned to our waivers. We have another 1,275,000 slots that will be allocated on July the 1st of 2025 at the beginning of state fiscal year 26. So reimbursement, we have to have a methodology, and CMS has to approve that methodology. And as I stated before, most of the services that are included in the home and community-based waivers are not covered by Medicare. They are not covered by commercial insurance, so we don't have a benchmark to compare to what the reimbursement rate for these services should be. So we did embark upon a waiver rate study. Because we have no defined waiver rate methodology, and again, CMS will not approve waiver applications without a sound and defensible rate methodology. So we did contract with Guidehouse to conduct a rate study for all 1915C waivers. They looked at cost and wage surveys. They talked to providers, and we did not include services such as physical therapy, occupational therapy, or speech therapy because those are a little bit more complex when we look at the waiver population and those services. And so we do have a plan to evaluate those separately. Rates are based on assumption and industry data when provider data was unavailable or insufficient. So again, not covered by Medicare, not covered by commercial insurance, so nothing really to kind of compare and benchmark against. So the objectives of the rate study were definitely to develop rates that reflect individual participant needs, that consider reasonable and necessary costs for providers, provide fiscal stability for providers, participants, and the state, and to create rate parity across all waivers for like services. And then again, to just balance efficiency and economy with appropriate access and quality to care. And we also wanted to increase transparency for participants and providers. Lots of activities went into the rate study. As I mentioned, the cost and wage surveys, partner engagement. We met with providers, legislators, state staff, got feedback on the rate development process, and then the rate modeling and benchmark data development. We do have a completed rate study report that is very comprehensive, that is publicly available. If you haven't seen that report and would like to see it, I would definitely bring it up to you or send it to you electronically. And prior to us implementing our rate study, during COVID, we had a flexibility called Appendix K that allowed us to increase rates for certain services that were being offered through our home and community-based waivers. As you know, home and community-based waivers are just that. They are in the home. So COVID did impact some of the workforce, so we definitely wanted to make sure that workforce was available. So there was a 50% increase for providers offering specific services if they passed along 85% of that rate to their direct care workers. And also in the 2022-2024 biennial budget, it allowed for an increase for all services for 10% for 2022 and then in 2023, and another 10% in fiscal year 23-24. It also maintained that 50% rate increase authorized in Appendix K. So there were some, during this period of time where we were doing the rate study, there were some modifications to the reimbursement rates. And as you can see, these are the costs of the waiver programs over time. These 23 and 24 that you're showing, there were no additional slots. This cost of the program or cost of the waiver programs, those 23 and 24 was the 10%, the two 10% and the 50% that were added to the cost of the reimbursement as we move forward. The rate study impact, the Beshear administration budget bill did approve an increase to bring all rates to 70% of the rate developed in the rate study, and we'll get into that just a little bit more. But the total increase, when you look over in aggregate, it's about 82% of an increase to the reimbursement that providers were receiving before January 1st of 2025. Some of the providers received a rate increase, and no, we did not decrease any rate. That was one thing that we wanted to do, is ensure that providers maintain the level of reimbursement they were currently receiving. And as you can tell on this slide, when you look at the rate comparison, the benchmark rate study is the rate that was developed based on that rate study completed by Guidehouse. 70% of that benchmark rate was funded in the, we say was funded in the biennial budget. So the rate as of December 31st, 2024, you can see some of those rates are higher than that 70%. So the rates effective January 1st, 2025 are actually what was budgeted in the funded in the 2024-26 budget. So that is just a little bit misleading, because 70% is what we had calculated with that the budget would be able to accommodate. However, when we looked at some of the rates that showed that they were already higher than the benchmark rate, we decided to keep those higher rates again, so that no provider received a reimbursement. And as you can see, these do not look like large dollar amounts, but the other thing that we take into consideration is the volume with which those codes are billed. And you can see again where the rates are higher. For example, you can on this page, the behavioral support services, the benchmark rate was recommended at $30.90. Providers were already receiving $4.23, so we kept that rate, and there is a rounding error in the table in that calculation that shows $40.24. You can see at the bottom, the behavioral health support plan, that changed from a 15-minute unit to a per plan. So the benchmark rate as calculated would have been $741. Based on the activity and the billing that is currently being conducted, we calculated that rate to be $885. So again, that rate is more than what the benchmark rate would have seen. On this rate comparison chart, you can see that the biggest differences are in our case management. The benchmark rate was established at $335.61. However, some providers were receiving $525.14, for example. Again, didn't reduce any current reimbursement rates. We tried to make the case management rates as equitable as we could within the confines of the budget and with what we were seeing in the delivery of services. So that's where you see some of the bigger disparities. And case management is a per member per month cost. So each provider that delivers case management services would bill that per member per month. Again, here's just the waiver rates in all transparency, just showing what the benchmark rate was, what 70% would have been, rate as of December 31st, and the rates on January 2025. I know that was a lot of information. Is there a lot of numbers, any slide you would like for me to go back to, or any questions that you have?
Yeah, and I appreciate that, Commissioner. There is a lot of information to digest and so forth, and but I just wanted to like to go back to, just if you don't mind, I'd like to go like maybe not slide by slide, but just pick out a couple of slides that I want to ask you some questions about. On the first slide, or I guess slide 3, it talks about the FMAP. You mentioned about nurses and in IT, about enhanced and so forth. I know there's been discussions on the federal level as far as bringing that down to 50. What does that mean into the general fund budget?
In the event, and I'll defer to the CFO too, but in the event that any of the FMAP is reduced, then we would, in order to maintain current level of services, it would mean an increase in need for state general fund dollars.
And have you gone through that calculation? And if so, what is it?
I have not gone through that calculation on the nurses. I have gone on that calculation on the expansion. If the expansion decreases from 90%, it's about $75 million for every 1%.
So every 1% decrease, it's $75 million. So if they go from, let's say, 90 down to the administration, that's 400 basis points take 400 times the 75 million. That's what we're looking at, hypothetically.
Hypothetically. Yes.
That's pretty serious.
That's why we think it's important to understand all of the FMAP right now in the Medicaid program. We are, continue to monitor at the federal level. We can't plan until we actually know what's going on, but at least we can be prepared to know the impact to the state.
And I'd also say that they're also looking at where you see informational technology, we get a 90% and a 75% on DDI design, development, and implementation activities of new systems. They're looking at decreasing that and not allowing that anymore and making that 50-50. That would depend on what systems every year that we're looking at doing a building or implementing. So it would really depend on those AP advanced planning documents that we submit. In 2024, our spend on those advanced planning documents, if I did it at the 50-50, it would have resulted in about, I have that number, I just can't remember it off the top of my head, but I want to say it was like $50 million.
$50 million.
On the admin side.
Per percentage decrease?
No, that was total.
Overall.
That was bringing the 90-10, anything that was paid at 90-10 or 75-25 on the admin side, if I reduced that to 50-50, what that impact would have been.
Okay.
And again, those are just projections.
Those are just
understand.
numbers.
Oh, yeah,
and I prefaced that with saying, it really depends on what systems we're implementing in a given year on what that impact would be.
Right, and I think this committee, as well as overall approaching revenues responsibility, we need to get that information as soon as it comes down the pipe from DC. Then we need to basically prepared. So, in the terms of reducing the benefits of 71, say they go down to 61 or 50, what's the decrease in that per point or per percent?
I think what you're talking about is there's like 9 states that are below that 50%, but actually that is the floor that they built. They're looking to do away with that floor, so they would actually get less for those 9 states. I think DC was one of them. I think is what they call it, the DC FMAP. But our benefits FMAP would not be impacted by that.
So, okay, I'm a little confused. So if
every
if
state,
the Congress goes down and say, all right, we're going to change the benefits from 71 go down to 65, that's not going to be an impact on the general fund?
oh, that would be an impact if it dropped, but that's not what they're talking. They're not discussing and dropping the FMAP for that.
Yeah, the FMAP is calculated based on a variety of factors in the state, and it is codified in federal legislation. So they would have to change federal legislation to. But what they are talking about is, as Steve said, the FMAP for every state is different. Some states are getting the 50%. There is a floor of 50%. Nobody will get below 50%. So they're thinking about changing that 50% and just having the calculation that they use for every FMAP be the same. I know it gets a little complex when they start, with the calculations, but. The FMAP is based on the number of individuals that live at or below the federal poverty level, the number of uninsured, and a few other factors.
Compared to the national average.
Okay.
And that's why Kentucky's is a little bit higher than some states.
Okay. I know there's a question from Representative Johnson before I go to him. In terms of in looking at the waiver enrollees, I'm speculating it's around 10% of the total. What does that equate to in terms of total benefits overall that
expenditures?
Mm-hmm.
We have we can get those exact numbers. We currently have 90% of our enrollment is in managed care organizations. The other 10% is either in a 1915C waiver or a long-term care facility, and that 10% accounts for about 20% of our costs.
20% of costs. Okay.
But that includes nursing facilities,
It does include the nursing facilities.
Okay.
But we,
not just waivers.
I had a little higher than that. I had it at 30. So,
Well, it used to be, but then when we did the directed payments, and those directed payments are
Okay.
paid through the MCOs.
Okay.
And so that's made that number go down.
gotcha. Okay. All right. Representative Johnson, you had a question?
Thank you, Mr. Chairman. If you want to go back to slide 12, might be a good place to land while I ask this question. So with waiver enrollments and waiver the wait list, if I understand correctly, there's two different sets of criteria for enrollment versus wait list. Is that correct? And if there is, what are the differences?
well, and I don't think there's two different criteria. It's just you have to meet level of care for the waiver. Some individuals think that they may meet criteria, not now, but at some point in the future, and they know that there is a wait list. For example, as you can see, we have 3 waivers: the home and community-based, the Michelle P. waiver, and the Supports for Community Living waiver that have wait lists currently. So in order to be qualified, they would have to definitely meet long-term care level of care for long-term care. The difference between the wait list and the actual individuals who are enrolled is some of those individuals on the wait list, we do not have an assessment for individuals on the wait list. So they have not gone through the assessment to see if they would actually qualify for the waiver at this point. And I do know about almost half of the individuals on the Michelle P. and the SCL are children under the age of 18.
So
Not quite half, but almost half.
just so I understand the process, they could actually go onto the wait list without being qualified to actually receive the waiver, with an anticipation that by the time they get through the wait list, they might qualify. And if they're not, do they go back to the bottom of the list, or are they just on the hold, or what happens?
If they don't qualify for the waiver, then there's no other. If they are determined, if an individual is determined not eligible for waiver services, I mean, they could potentially go back on the wait list to see if their condition changes, because sometimes individuals, their medical condition just change. But if they're not eligible for the waiver, they're just denied the service.
Okay, what an interesting process that these families have to go through.
Yeah, we are definitely working on that wait list process to make sure there is a plan to look more in detail at those individuals who are on the wait list to see if they would actually qualify. I mean, it is just, it is disheartening that some of those individuals would actually qualify if we had the slot available for them. But we are working on that to definitely give the families and the individuals on the wait list a little bit more of an indication on whether they would actually qualify. But again, that's only as current as their medical condition today. If it continues to change, then they would have to have another assessment to see if they qualify.
So it's first come, first serve. If they make it to the top of the list, they are evaluated. If they're evaluated, they can make it to the waiver. If not,
Yeah, and we do have some emergency. There are some emergency provisions. So yeah, it is somewhat of a complex process. We understand that, we do know, but the waivers again are services that commercial carriers and Medicare does not cover. So, and as of the Medicaid program, again, the Medicaid program is going to be 60 years old this year. The waivers are still a little bit new in relation to the age of the Medicaid program. Still a lot of things that we're figuring out. So definitely keeping an eye on that wait list and everything that we can do to make sure that the numbers of individuals that are on there actually would qualify for that waiver.
Representative Johnson, if I may add too, I just want to make sure that everybody understands they would still be receiving services through our state plan services. It's just those waiver services they are waiting on. So they're still getting services through the Medicaid program, but it's through what our normal state plan services are.
and
that's,
that wouldn't impact their services if they were.
This does
Got
not
to the top
impact
of the list
if
and
they
we're disqualified,
qualify
it
for
wouldn't
Medicaid,
impact-
regardless if they're on a waiver or not. They
All right, good point. All right.
yeah,
thank
so and that's if they qualify for Medicaid. If those individuals on that wait list qualify for Medicaid, they are receiving all Medicaid eligible services. They're just not receiving the home and community-based services such as those personal needs, personal care services. So they would still be receiving Medicaid covered services.
I saw your eyes, so I didn't want you to think that they're just sitting there
Yeah.
That's- well,
and not getting any cleaning services.
You may
because
see
they are.
smoke coming out
Yeah.
of my ears. This is quite a learning
Yeah, but
curve.
that-
Thank
but-
you, Mr.
But
Chairman.
that if
You're
they
welcome.
qualify for Medicaid, and again, those individuals, some of those individuals in Michelle P. and SEL are children under the age of 18, and as I stated before, children's eligibility in the waiver program is based on their income, not their family. So if they are in families whose income is above the threshold for Medicaid eligibility, those children are not receiving services.
You're welcome. Commissioner, there was an October report on the waiver list management assessment, which
Yes.
I know you're familiar with. In there, and I'm just trying to get some clarification in my mind. It says funded enrollment cap for each of the 6, but there's a lesser number in terms of enrolled. I guess, or are we funding the funded amount and the only the enrolled amount we're providing service? There's a gap there. I'm trying to justify that. Is there money sitting there, or has it been? I don't know. Could you give me a clarification on that?
So the funded slots are definitely how much we have allocated. The field slots are individuals that are actually in a slot. Some of those individuals, you can see the reserved is, I think it may be, or the available slots are what we have that we can fill. I'll have to get some more definitions on that to give you a real clear definition of slots that are filled versus slots that are available. Sometimes individuals will move in and out of those programs. So I'll just have to get some more clarification. I do have that. I've asked that same question of my expert staff that oversee these programs, and I do have that and can send that to you in an email to clarify what each of those areas mean.
Yeah, and I appreciate that in terms of, if we're funding X, like 100, and only enrolled 80, what's going on with the money that we've allocated an additional 20?
And we would only expend those funds that are for individuals who are actually receiving services. If there's
Okay.
funds allocated, we would not, and somebody is not in a slot, for example, we would not be drawing down or expending any money for those individuals.
Okay, so all right, but apparently you have this money it's holding there, I guess, waiting for people to be enrolled that we've already funded at 100%, whatever the cap is. So if that money is sitting there, how long will these individuals be put into the enrollment? I mean, I'm trying to get a feel, and I appreciate you sending me a flow chart of
we
this, of the whole process, and it seems to be pretty time consuming.
Yes.
So if somebody comes in and applies, and it takes a year, well, that money's sitting there for a year. Is that the best way for us to use that money? Just let it sit there, or what? Like I said, I'm just trying to get a clarification of that.
And that again, that is a really good question, one that I will have to go back and have my experts who administer these programs explain. Again, I do have the information, and I just wasn't prepared for that question today, but we will get that information back to you and make sure that we answer both how that's allocated and the funding.
Okay, I appreciate that, and obviously we ask that because that becomes in a budgetary. We don't want to shortchange what people getting ready to get into the program by enrolled, but then again there is a delay, and so we
Yes.
want to make sure that the money is going to those folks who need the benefit, the services. Yeah, yeah. Just send it to staff, and they'll send it out. Thank you for the reminder. I guess it's page 13, maybe the next slide. And I just did a quick calculation, and hopefully this is right. Right now, I think it's around $1.6 billion under this program. With the additional slots, that's going to bump it up to maybe over a little more than $2.1 billion in order of that. And it seems to me that the home and community-based waivers is the most, and the supports of community living is second. Is that an accurate assumption on my part?
Yeah, yes, I do think that's an accurate assumption.
Okay. Alrighty. Okay. I know some time ago that there was discussion and maybe even a plan to look at redesigning the waiver program. Could you comment on, I know that was looked at and then it was dropped or it wasn't addressed anymore. Could you give me some explanation or background on that if y'all going through and considering that?
Yeah, so the redesign of the waiver program did correlate with the rate study, the reimbursement portion of the home and community-based waivers. There had been talk several years back about redesigning the waiver programs just to make them more aligned with services. For example, we have also discussed recently making the redoing the regulations, for example, to have everything that is related to participant-directed services in one regulation, just to make it a little bit more streamlined, make it easier for people to understand. Then COVID happened. We did complete the rate study, so that was the first step. We're continually evaluating to see what services or what changes need to be made. Again, one thing that we're looking at right now are the physical therapy, occupational therapy, and speech therapy services, looking at their rates, looking at how those services are delivered, and if we need to redesign that. Because one of the reasons for the redesign and looking at the way that services are delivered is that the Centers for Medicare and Medicaid Services that give us most of the money for this program wants to ensure that I've lost my train of thought. I'm sorry. The Centers for Medicare and Medicaid Services want to make sure that services that are, we talked about the state plan a few minutes ago, individuals who are on the wait list can get services in the state plan. So the Centers for Medicare and Medicaid Services says if your services are covered in the state plan, they cannot be delivered by a waiver provider. There are some services, for example, the physical therapy, speech therapy, and occupational therapy that was not included in our state plan until 2014. And so redesigning those waivers means aligning those services to ensure that they're being delivered appropriately, either in that state plan benefit or the waiver benefit based on federal regulations.
Okay. All right. Well, I appreciate that, the clarification. I know I'm finding that there's a lot of ifs, ands, and buts, and whereas, and all that good stuff, not only on our laws, but also the feds. So I appreciate the clarification of that. Just a comment on the rate study that you mentioned a few minutes ago. The vendor went out and extracted information from providers on what their rate is. But to me, that's a sort of a self-fulfilling prophecy because it doesn't really reflect market rates. And so even though we're looking at this in terms of costs, you know, we pay our folks, you know, we get reimbursed like $80, $85 depending on the CPT code that we apply. But our costs in some cases much higher. And so when I report, I didn't participate in this rate study, but when I report, it's going to be say $90 in terms of my costs, but yet the rate is lower than that. And so we need and I just want to make a comment that it seems to me that there needs to reflect the market rate and not the cost, because the rate that's reported is suppressed and doesn't reflect reality. You understand where I'm coming
I do understand.
Okay.
And I think the rate study will have in their exact methodology, and they took other things into consideration other than just the survey from the providers. They did look at some market rates, but again, happy to share that full report with this committee so that they can review and look at those reimbursement rates and how they were developed.
Okay. I have one more question. We do have somebody who wants to who signed up to speak. What oversight, what type of monitoring do you have in terms of the whole program, in terms of reportability, utilization? What type of oversight is there that really keep things really keep things on tap? And then goes back to what Steve, and that is projection forecasting is going to be vitally important. And I encourage y'all to communicate with the General Assembly in both chambers on what we need to be prepared of, and what we need to be mindful of. That's going to be very important because we can be caught in pretty much a bad situation, and we're going to be looking to you all to provide accurate, timely information in order to do that. So anyway, what type of oversight programs you have in terms of the whole spectrum?
We do monitor utilization in a variety of ways, and I think next week we will be here speaking specifically to our oversight and monitoring activities, the algorithms that we have in the system. But from this slide, you can see the Department for Medicaid Services, our Division of Long-Term Services and Supports, oversees and administers the Acquired Brain Injury Program, the Acquired Brain Injury Long-Term Care, and the Model 2 waivers. We do work with our sister agencies to provide certain administrative and oversight activities. For example, behavioral health, developmental, and intellectual disabilities. They administer the Michelle P. Supports for Community Living. They have oversight regarding individuals, providers who are enrolled. They also help us manage that wait list. So we do have a variety of mechanisms to oversee the waiver programs, and we will definitely go into more detail into that
Okay.
next week.
Okay, well, good. I appreciate that. Does anybody else have any questions before we have the next? I do want to recognize Representative Raymer and Representative Wilson in attendance. Okay. All right. Well, thank you all very much. Appreciate participating. If you don't mind, just stick around in case somebody has a question that pops in their mind. They can ask, but appreciate that. And we'll obviously, if we don't speak like this in format right now, we'll see you next week.
Yes, thank you
Thank
so
you.
much for having us here.
As a person moves up here, we do have a quorum, so I'd like to entertain a motion to approve the minutes from last week. Is there a motion? Where's a motion? Is there a second? All right. All in favor, say aye. Aye. Opposed, say no. Very good. Thank you all very much. Okay. Well, thank you very much. If you don't mind, like I did the last time, I appreciate it. Did you swear to tell the truth, the whole truth, and nothing but the truth?
I do.
All right, very good. If you don't mind, just introduce yourself on your a little quick of your background and what you like to present. Thank you.
Good morning, and thank you for allowing me to be here. My name is Amy Stade, and I am the CEO of the Kentucky Association of Private Providers. We are a trade association representing providers of 1915C waiver services in Kentucky. So our members provide services in all but one of Kentucky's waivers, and that is the Model 2 waiver for our event-dependent population. I don't think any of our members provide services there, but everything else we cover. Again, thank you so much for allowing me to be here. Commissioner Lee touched on a lot of what I wanted to touch on, so I'm going to kind of gloss over some things. But from the get-go, 2 additional items I just really wanted to highlight about our waivers. Commissioner Lee said this, but I just wanted to reiterate that 1915C waiver services in Kentucky they're different than our other Medicaid services because they are 100% Medicaid funded. Obviously, 70% of that comes from the federal government, but the Medicaid program pays for 100% of it. These providers don't get reimbursement from other kinds of services. They're 100% Medicaid reimbursed and completely and totally dependent on the Medicaid program to pay their employees, to pay their costs, pay everything. So that does make them slightly different than other Medicaid services. And 2, the population who engages in 1915C waiver services is truly the population that the Medicaid program was designed to support. Again, they meet institutional level of care, but without access to these services, these individuals would be receiving care in institutional settings. So that would be an ICF, a nursing facility. And when you compare the cost of those, for example, for the SCL waiver, that would be an average of $286 a day per person versus over $1,200 a day in an institutional setting. So they really are a cost savings for the Commonwealth to provide these services in community-based settings. Commissioner Lee talked a lot about the rate study, but I did just want to highlight a few key dates related to that. So beginning in 2017, the Cabinet for Health and Family Services contracted with a vendor to redesign Kentucky's waivers. By 2020, most of the redesign recommendations had been implemented. So actually a tremendous amount. Our services were redesigned quite a bit 2019-2020. The outstanding redesign initiative was the completion of a reimbursement rate study. So in 2021, the General Assembly had a bipartisan legislative task force. Recommendations from that task force recommended a two-prong approach to shoring up reimbursement for waiver services and improving the quality of services. And those recommendations were to, one, bolster the workforce, and two, address funding for both services and slots. Following that legislative task force, in the 2022 session, which was a budget session, the budget allocated funding to providers that included rate increases in that budget that allowed providers to increase wages and things like that while the rate study was being completed, while we were waiting for the results of the rate study. In November 2022, the Cabinet for Health and Family Services announced that our waiver rate study was complete, but that report was not released until August 2024. In the 2024 budget, the General Assembly included $94 million in general fund dollars and $236 million in federal matching funds to be used to implement the rate study and, quote, update and increase benchmark reimbursement rates. On June 5th, 2024, the Cabinet for Health and Family Services announced that it would implement the rate study at only 70% effective January 1st, 2025. To say that providers and families were shocked and deeply concerned by this 70% implementation plan would be an understatement. Because any changes to our waiver, reimbursement rates, or methodology has to go through a public comment period. It's required in the federal regs, and then be submitted to CMS for approval. The rate study and the 70% implementation plan was released for public comment in August 2024. This was the first time in nearly 2 years since the rate study was completed in November 2022 that stakeholders were given the opportunity to review the rate study report. The rate study report details methods, assumptions, data. There's lots of stuff in there that goes over my head. I'm not a statistician. But in the rate study report, Guidehouse, who was the Cabinet's contractor, reported the fiscal impact of the 70% implementation plan that was outlined by the Cabinet for Health and Family Services in the June 5th letter, and that was eventually implemented January 1st of this year. Guidehouse concluded that the total general fund cost for the 70% implementation strategy was $68 million, $26 million less than the General Assembly appropriated to implement the rate study. Providers remain confused about why the rate study was not implemented closer to 100% funding by using all of the appropriated funds to, quote, increase the benchmark rates as required by the budget language. So what's the impact of that decision? We've seen impact in three key areas. One, provider sustainability and access to care. Two, workforce. And three, inflation. So one, provider sustainability and access to care, probably the most important. As you noted, the rate study took a look at actual provider costs. They reported actual data, including pay rates, benefits, insurance, taxes, workers' compensation, and other costs of doing business. Like you said, that can be a bit of a self-fulfilling prophecy, but especially when it comes to wages and reimbursement rates. But the providers did report actual data. I want to reiterate that the rate study results are the rates, reported the rates that it would take to, one, offer wages that could at least compete with fast food wages, and two, allow providers to keep their doors open. So the decision to implement only 70% of that was disastrous for many providers, especially residential providers who provide 24-hour care 7 days a week, who are depending on the 100% implementation so that they could attract a better workforce and keep their doors open. Many providers, unfortunately, specifically staffed residential providers, have decided that the 70% implementation isn't sufficient, and so they may be closing their programs here shortly.
Okay. Yeah, if you don't mind, just one more minute, because we're butting up against I don't mean to cut you off, but I just want to let you know.
Yes. Quality workforce. The rate study recommended recommended rates that would be sufficient to support about a $15 an hour wage. 70% implementation supports about a $10 an hour wage. And then inflation, the rate study was out of date on implementation. The rates were only inflated to June 2023, which was the anticipated implementation date. Obviously, it was implemented in 2025, so they were out of date at implementation. We understand that there's lots of uncertainty on the federal level. We're very concerned about the FMAP as well. We're just asking that 100% of the funds that were appropriated be used for the appropriated reason, and that is to increase the benchmark rates.
Okay. Thank you very much. Is there any questions from committee members? So I guess your concern is one, the timeliness of the notifying the public, the providers, on the reports, and delay in reaction on what's going. That's one your concern. Is that correct?
That was correct, yeah.
So, okay. And the other one is obviously the 70% in terms of getting reimbursement that you mentioned. So the recommendation, I guess let me if the commissioner, would you mind just sort of responding, or Mr. Bechtel respond to that? I just want to get that clarified. I think I know what you're conveying, but I just want to hear from the staff or from DMS.
So the question is why the 70th percent? As you know, as she said, I'm not sure, and maybe I can ask her a question. The difference, did you say in the Guidehouse report, the $68 million, was that across the biennium or just for 1 year?
The Guidehouse report.
Thank you.
The Guidehouse report outlined in the one that was released for public comment, outlined that across the biennium, it would take $68 million appropriation, so $68 million in additional funds on top of the funding you already have to fund that 70%.
Okay, I'll have to go back and look at that report because that's not in line with what I'm seeing. When we chose the 70th percentile, it was based on the funding that we received in the budget. So what we received in the budget, this is what we're allowed, what I'm going to be able to afford, right? However, I will say this. We chose the 70th percentile, but the rates that we chose, and you can look at that on our slide, at the very end of our slide decks, you can see the rates that we chose were above the 70th percentile for each one of those almost. There's only a few that's at 70%. If you do the actual rate that we chose and divide it by the benchmark rate, that'll get you the percentile of that rate that was chosen. When we've looked at it across all rates, we're around 92 on average. You're going to have some that's above 100%, and you're going to have some that's right at 70. But when you look at that, all those rates on average, we're average around 90% of the rate study for each rate. Each rate.
So y'all recommended to the General Assembly funding 100% of the 70%.
Of the 70%.
Right.
But, however, we also have our baseline from 23 that included the 10 and 50.
Okay, and then but looking at 100% is more of a monetary constraint in terms of
Yep.
going up. That's what you're telling me.
Correct.
Okay.
But I'll need to go back and look
Yeah, and I
at the
appreciate it. If
report
you don't,
and do a little bit.
Yeah, if you don't mind, Mr. Beck, if you could
Was
just
that the
communicate.
October report?
It was the one that was released for public comment, that was posted in with all the other public comment
I'll
documents.
have to go back and look.
Okay, if you don't mind, would you mind communicating that? That's a good question that she raised. If communicate that with the staff, and then we'll make sure that you'll get your answer. But any other question, Mr. Or Representative Johnson? And we
Yeah,
have
just-
about 3 minutes,
Yes, sir.
4 minutes left.
Very quick. Just to verify, and it just popped in my head, the money that we have allocated for these programs, can you verify for me that 100% of the money we allocated has gone directly to the reimbursement or to the programs themselves?
Yes.
Okay, thank you.
Any other questions? Very good. Thank you all very much. Appreciate coming here. If there's not any questions that I see, we will Nope, thank you. We will reconvene next Wednesday at this room at the same time. And if there's anything else, I'll entertain a motion for adjournment. Nope. And a second, we got